The Division of Integrated and Continuing Care, we call it DICC, I think it was set up with the intent to look at how we support patients who require a recovery period after the acute care. So if you look at the entire division, we have different departments like the geriatric medicine, we have palliative medicine department, we have the community hospital, which we call PARC, P-A-R-C. We also have medical psychiatry. And of course, recently we also added in the preventive and occupational health medicine branch. So all in all, if you look at it, it's very much to support patients in the recovery phase after the very, very acute stage of the illness. And besides that, we also have this transitional care service where we look at how we transit patients from the acute or inpatient setting to the community setting. So it's set up with the intent to help patients slowly transit from the acute phase to the subacute phase and eventually recovery in the communities. So many of our patients with chronic illnesses or who may be slightly frail, when they are admitted to the acute setting, there is what we call functional decline. Right? So when there's functional decline, to get them back to the previous state so that they can then function and return to their own home. So that's the part that's very important because when you come into the hospital, after a few days stay in the hospital, in the ward, in the bed, you realize that you get weaker in the legs. That's when you need to bring them back onto their feet again, make sure that they can manage when they go home. So all these are different steps that we need to look into when we bring a patient through the subacute phase and eventually recovery phase of the illness. Part of my role is also to make sure that patients transit safely back to the community, and that requires a very close partnership with our partners in the community. So people who are running home nursing services, home medical services, even some of the social care agencies out there. So in the intermediate and long-term care, which we call the ILTC sector, we do have many partners who are really have the capacity and capability to look after patients in that group. As Singapore ages, we realize that many of the elderly patients have conditions which are recurring, and many of them may actually choose to be managed in the community setting rather than coming back to the hospital. So it's well known that for an elderly to come to the hospital for treatment, and there's a very high risk that they actually catch. So to avoid that, sometimes to help them manage the conditions or treat relatively simple conditions out in the community without the need to come back to hospital becomes very important. So I think as the population ages and there are different options available in the community, I think that forms a very important option for them. And that's what we are trying to do for Woodlands Health. Really, can we be a hospital without walls? We go out to the community, we provide that care for them. If possible, there's no need for them to come back to the hospital so that they can be well taken care of in the community. But to do that alone, for Woodlands Health, I think it's tough. We only have a small, limited number of staff out in the community. We need to work closely with our partners. And that partnership is very important.